Good morning, everyone. Is my screen visible?
Yes.
Yeah. So I'm going to speak to you about one of the commonest injuries in the finger, very common in our country because of our passion for cricket, and it's a cricketing season when we see maximum of these swollen, jammed fingers, and most of them turn out to be dorsal dislocations. Unfortunately, not many of them uh, present to us in the acute situation. So this is a simple dislocation. There's no fracture involved. This was a 52 years old, highly placed government official, and these are the ones which will typically, unlike the metacarpophalangeal joint dislocations, these will typically reduce well because the volar plate typically will not interpose in these fractures. So on reduction, they look like this. So they reduce without any difficulty. That's where the problem starts. If you look carefully in this case, if you look at the angle between the middle phalanx and the proximal phalanx, it is in hyperextension. This indicates there is a soft tissue injury on the volar side, the volar plate. So for this fracture, for this dislocation to heal well, and for this joint to remain stable, it is very essential that we maintain it in flexion so that the volar tissues heal well. At the same time, any dislocated joint, if it is simply immobilized, will lead to a lot of stiffness. So you need to also keep moving this joint within a safe range of movement. That is where extension block splinting comes into play. So this is a very simple way of putting an extension block splint. As you can see, now the joint is in about 30 degrees of flexion, and this is how these are the two aluminum foam splints which are bent around in obtuse angle, and when the finger is attempted to extend, the two ends meet here, so they do not allow any further extension. So then, and the person is able to carry on with the activity. Further flexion is completely allowed. The second simple form is where there is a small volar chip, the joint is reduced well, and this is how the patient presents. Now, this is where the dilemma comes. Should you actually fix this? The phalanges look well aligned. There is no hyperextension. So now this is where the patient cooperation comes into picture. If you believe that the patient will listen to your instructions very well, you can treat this completely non-operatively, sometimes even without a splint. So what instructions the patient has to follow? The patient is allowed to bend the finger without any force. So he's allowed to move but not use the hand. And if the patient does not hyperextend forcefully, this will go on to heal well. Even if this bony chip does not heal, he will continue to have a good function. So this is the end picture. The soft tissues have healed, the joint is congruous, and patient has complete range of movement. Then when and why do we at all fix these fractures? Do we really need to fix this fracture? Just have a look at this diagram. This is the proximal phalanx, middle phalanx. The red one is the collateral ligament proper. The yellow one is your accessory collateral ligament, which inserts into the volar plate. This is yeah. So if you now correlate here, this is your proximal phalanx, this is your middle phalanx base, and this is your dorsal dislocation. Now, if you just focus onto the bone, and this is the middle phalanx base is the problematic area. So let's temporarily get the proximal phalanx out of equation completely and focus only on the base of the middle phalanx. Now, if you look at the base of the middle phalanx, more than half of the base is intact. So this is where about 30 to 40% is lost to comminution. Now, when you have middle phalanx base, which is 30 to 40% lost, you can reduce this fracture, and this would usually remain stable. Why would it remain stable? Because the collateral ligament is attached to the base of the middle phalanx and not to the comminuted area. So when you reduce, what happens is the collateral ligament will make the joint stable. However, this volar restraint which was avulsed attached to the volar plate remains where it was. So if this has to heal well, you will need to keep the joint in flexion. That is where the concept of extension block splinting or preventing extension comes. So this method is suitable where there is only 30-40% loss of the joint surface. Now it may be difficult to assess this 30-40% joint loss. So another indirect way of assessing this 30-40% loss is if the joint remains stable in as little as 30 degrees of flexion, then you know that this joint is stable. If you require more than 30 degrees of flexion to keep the joint stable, then you can judge that the loss is very likely to be more than 40%, and those are the unstable varieties. So once the stable varieties, the ones which remain stable in 30 degrees of flexion, the ones which have 30 to 40% loss of the articular surface, once you achieve stability, all you need to now do is uh, give some sort of extension block. One example you already seen in the first example. The other way is simply put a K-wire into the head of the proximal phalanx. So further flexion is allowed, but extension will not be allowed. Another way is you can simply put a splint on the dorsum. Again, further flexion is allowed, but extension is not allowed. So this is how the fractures will heal. You should encourage formation of flexion deformity in these patients. Once the flexion deformity forms, it acts as a natural restraint to further dislocation, and any flexion deformity can eventually be stretched out once the joint is stable and fracture has healed. So now take a second example. These are the fracture. You see the bone loss is obviously more than 50%. So one, you can have a visual impression of that for 50% loss, or you also know these are the fractures which will either not reduce or will require more than 60-70 degree of flexion to keep them reduced. So you judge that this is an unstable variety and this is more than 50% loss. What happens when there is a 50% loss? When there's a 50% loss, the collateral ligament is now attached to the avulse fragment and not to base. So even if you reduce these fractures, this fracture will remain unstable. So we need a formal fixation between the base of the middle phalanx and the middle phalanx itself. So there has to be a formal fixation here, which was not required in the earlier variety of fractures. So you can either put K-wires and neutralize it with an external fixator. Once you do this, you can get again a flexion deformity with a well-articulated fragment. Why do we really need to do this? Is the mechanism of why do we encourage flexion deformity? Because the force couple which is formed by the extensor tendon and the FDS tendon is the one which causes dislocation. Once you reduce the phalanx and put it in flexion, you are actually neutralizing this force couple. This also is a mechanism by which you can introduce so many modifications of this treatment, which is perhaps outside the scope of this discussion. So once you have encouraged the flexion deformity, then you start stretching it out by using this spring splint called as a Kapner splint. Remember, this splint is to be used only after complete healing of the fractures. So typically not before 3 months, typically at 12 weeks. Sometimes you may use it for beyond 6 weeks, but definitely not in first 6 weeks. This is only for stretching out the flexion deformity, and this is not the treatment of the dislocation. So I will run you through a few examples. Again, you can see almost more than 50% of the articular surface is intact. Comminution. If you choose, you can choose to treat this in a just a flexion block. However, the loss of articular surface will not restore itself. So it is much better that we do a proper formal open reduction for this type of patients. Remember, this is an intra-articular fracture. The basic principle of intra-articular fracture fixation holds true here as well. Anatomical reduction, stable fixation, and early mobilization. So this is how you can get an excellent result even in these patients. So this is another example. where there is an articular depression. In earlier case, you saw there was a comminuted fragment on the dorsum. Here, there is an articular depression. How would you do if this was a tibial condyle fracture? You would elevate, you will get it to get the articular surface to alignment, and you will buttress. That is exactly what was done here. This was the depressed fragment, reduced, and there was a void here which was filled using bone graft, fixed using three 1 millimeter interfrac screws, and a perfect alignment of the intra-articular fragment achieved. And as little as 2 weeks, you start getting a good range of motion. I'm never really worried about. I'm really never worried about the flexion deformity that the patient has. I know I will be able to stretch it out eventually. Sometimes you have a fracture like this where a reconstruction is just not possible. The articular reduction is just not possible. You can still put a few pieces together as long as you have more than 50% of the articular surface intact. And in that case, you simply can use a pull-out suture. You can see this is a button, and you can still see a reasonable articular congruity. These patients will also go on to do well. Again, I'm not worried about the flexion deformity these patients will develop as long as they're able to flex from 30 to 40 degrees to 90 degrees. And this is I think as little as 6 weeks that the patient was in this state. And now I will stretch it out from here on. There are situations like this where there's a massive loss of articular surface and very little articular surface left. So you have this entire part which is lost, something like this. Now you can treat this in two ways. This was treated in one particular way. This was a volar plate arthroplasty that was done, and an extension block splinting was done. Second option is a hemi-hamate osteochondral autograft. So these are the two salvage options you have when you have a loss of volar plate. Now, what I mean by volar plate in the earlier case that I showed, this is a volar plate arthroplasty. So what I did in volar plate arthroplasty, now just imagine this diagram. Now just extrapolate it to this line diagram. This to this, this to this. Now, this is what is done in a volar plate arthroplasty. So this is your volar plate. This is your comminuted bone fragment. This is a dislocated area. So this is the bone pieces which normally you would want them to be reduced like this, but you cannot because there is severe comminution. So you simply remove the comminuted bone fragments. Now you are left with this defect, and you are left with a volar plate. So what you do is you simply remove the bone pieces and interpose the volar plate. There are sutures attached to the volar plate which are brought out onto the dorsum and tied to a button. So that is volar plate arthroplasty. Now volar plate arthroplasty is good if you have about 50% bone intact. Problem is, because it's a soft tissue restraint we are creating, it can stretch out over a period of time, and you can get recurrent subluxation. So this is the example that I showed you. This defect is filled with volar plate. It's not empty. It's filled with volar plate. And this patient has got, I think this must be around 3 months post-operatively, that this patient has got excellent range of movement. This is the patient. He also had an old Malay injury, and he has this deviation of the fingers on both sides. So this is the IP joint that even with the volar plate, it has done very well. So when you don't want to do volar plate, so similar fracture, you saw that hardly any part left. So more than 50, I would say, I would put it almost 70-80% articular loss. When you distract, this is the defect that you get. There is no way you're going to fix this. So, and when I open on the volar side, this is what I found. This is the head of the proximal phalanx. This is the dorsal lip of the middle phalanx, and this is the comminuted fragment. So this is what was done. This comminuted fragment was completely removed, and it was replaced by this bony piece which was retrieved from hamate. So this is a hamate graft that is put, and it is fixed using 3 screws, and this is what you get. So this is what you get. That is the defect. That is the hamate graft that is taken out. And it is eventually fixed like this. And on table, this is your range of movement. Sorry, this is your on table range of movement. This surgery is done wide awake. This is on table. Now, this was done almost 5 months post-operatively, and this is about 3 months. And this person will have a joint for life. The arthrosis, the formation of arthrosis will be very, very late. To summarize, when you have pure dislocation, remember it's a volar plate injury. It will require extension block. If you have a stable fracture pattern, it can always be close reduced. Again, you're in a flexion block, extension block. If you have an unstable fracture pattern, just like any other intra-articular fracture that you would treat anywhere else in the body, fix, get an anatomical and stable reduction and start early mobilization. Simple immobilization is not a solution. When you have a neglected fracture dislocation, a volar plate arthroplasty or hemi-hamate arthroplasty can still give you a joint which can last the patient a lifetime. Thank you very much.